for you, Brendan. Good.
All right. Well, Gary just said, who starts at me or you? So I guess I'm starting this program. Hey, everyone, thanks for meeting us today for our usual Friday NMQF webinars. I'm Brandon Garrett with the National Minority Equality Forum. Just happy to see you here. This is actually going to be our last webinar of 2024. So thank you for joining us today, but thank you for joining us throughout the calendar year as we try to continue to do these programs and sort of educate and get everyone together around certain topics. Today's program will be led by our very own Dr. Gary Puckrein. Obviously, I don't think Gary needs any introduction, but I'll say two things about Gary. Let's see off the top of my head. Gary is his PhD's in history, so he studies like how health has been impacted over a period of time, much like an economist looks at the historical markers and why the economy is where it is today, why is healthcare where it is today. And in addition to being my boss, he's my fraternity brother. So with all that, I'll let Gary go ahead and take over this webinar on the progress in the national effort to eliminate Hep C. So Dr. P.
Thank you so much, both you and Ashley, for organizing today's webinar. I'm really excited about the conversation that we're about to have. We have me personally, have been following the whole science around hepatitis C, which is an amazing science. When you start to be able to talk about curing things, I think it puts you in a whole different realm. And so I think you're going to hear a little update about where we are and what the opportunity lies. So I have really two great presenters today, Rachel Florence and Tim LeSean, who are going to help us through. So I'm going to turn it over to Rachel, ask her to introduce herself, talk a little bit about her background, and then hopefully talk about hepatitis C.
Yeah, thank you so much, Gary. And thank you to you and Brandon and Ashley for inviting us to talk today and for being able to kind of share a little bit of our journey and our efforts on hepatitis C elimination. So I work at the NIH and I've been there for 5 years. I joined for the COVID response. And I'm a health economist by background, but I was fortunate 3 years ago to be asked by Dr. Francis Collins, who's the former NIH director, to join him on this effort to launch a national initiative to eliminate hepatitis C. So that's been my focus for the last 3 years. And what I'm going to do today is talk to you a little bit about, I'll give you a little bit of background about hepatitis C and talk to you about this initiative that we've put together. And then my colleague, Tim LeSean, who's been leading a lot of the advocacy efforts, is going to talk about the outreach with advocacy groups and with Congress. So I do have some slides to share, so I'll pull them up. And here we go. So I'll be quick. I just want to give you some background, and I know it's nice to have a visual oftentimes. So here are some slides to talk to you about hepatitis C. So I actually didn't know a lot about hepatitis C before I started working on this, and it's a really fascinating area. It's a fascinating disease. It's a public health crisis in the United States, but we don't hear or know a lot about it. If you look at my graph here, there's two bumps in the epidemiology. There's millennials, so people who were born between 1981 and 1996, and there's baby boomers, so people born between 1945 and 1965, and these are the two populations that have a lot of hepatitis C in our country. We think the estimates, so it's hard to get exact estimates, but we think there's up to 4 million people that carry this disease in the United States. A lot of people are unaware they have it. We think it's maybe up to 40%. It's a silent disease. It can go on for decades in your body without you knowing that you have it. And then there's some serious health consequences that happen 20, 30 years on: liver cancer, cirrhosis, needs for transplant, and possibly death. We know that other countries have programs to end this disease. Egypt, the country of Georgia, England, Australia, all have like large initiatives. They're meeting their goals, and we in the United States are a little behind the curve here in terms of our elimination of this disease. This is kind of just a little graph to show you how the disease progresses. So as I said, it can be 10, 20, 30 years until your liver actually kind of gives out. And it's not a nice disease towards the end of your life. It's a very it's kind of an unpleasant and difficult disease once it starts being symptomatic. But the amazing thing about this disease is that we actually have a cure, and it's one of the very few diseases in our history and in medical science that has a cure. The virus itself was only discovered in 1989, and 3 people, including someone at the NIH, Dr. Harvey Alter, got the Nobel Prize for this discovery. It used to just be called non-A and non-B, but in 1989, they actually were able to identify it. And after that, they were able to screen blood, because it's transmitted through blood. I should have mentioned that. It's a blood-borne virus, and so a lot of the transmission in our country happens through needles and through needle exchange for people who inject drugs. But so as I say, it's now curable. It's the companies Gilead and AbbVie came up with treatments that were authorized by the FDA in 2013. They're 8 to 12 weeks course of treatment. You take the pill. There's almost no side effects. Almost anyone above the age of 3 can take it, except pregnant people in the 3rd trimester of their during the course of their pregnancy, but otherwise everyone can take it, and there's almost no side effects. So it really is a miracle of modern science. But as I mentioned to you in my first slide, a lot of people are still not accessing this treatment. And there's a number of reasons why this treatment isn't available to everyone. So as I mentioned, it's an asymptomatic disease, so lots of people don't know that they have it, and the testing hasn't been widespread. So about 40% of people we think who carry the virus are not aware they have the infection, so that's a big problem. Until June of this year, we did not have a point of care test, so you sometimes had to go 2 times, maybe 3 times back to the doctor to get your treatment. So you had to have first antibody test, and if that was positive, you had to come back, get your RNA test, another blood draw, and then you had to come back maybe a 3rd time to get your prescription from the provider. So as a result of that, lots of people were lost to follow-up, especially if it's asymptomatic. That was a big problem. But in June of this year, the FDA approved the first point of care test for Hep C. So that was a big milestone in terms of the fight against this disease. And we're hoping that will help accelerate getting people who test their treatment in the same day, in the same encounter with the provider. You might have heard that back in 2013, the cost of the treatment was really huge. I mean, I think it was I think it was about $90,000 for the course of treatment. And because of that very high cost, a lot of state Medicaids were just not able to afford the treatment. And so they had to put in a lot of barriers to access because otherwise it was going to break the bank for them. So as a result of that, we saw a lot of barriers put in terms of prior authorizations, and things like you have to see a liver specialist, you have to have evidence of liver damage, there were sobriety requirements, and so there was a whole bunch of things that were put into place essentially to stop people from accessing what was a very expensive treatment. The treatment cost has gone down since then, but unfortunately, a lot of the barriers have stayed in the insurance world. So that's also a reason why we haven't been able to provide this cure to everyone. Another problem that we have with Hep C is that it's not routinely tested or treated in primary care. So it's really still the specialists that take care of that. And of course, a lot of people don't go and see a liver specialist routinely. So that's been a problem. And we really need to get primary care providers willing and able to prescribe this treatment. A lot of providers remember the period where the only treatment was something called interferon, and that used to be a very it's a horrible treatment. It gives flu-like symptoms. You have to take it for many months. You feel ill during it, and a lot of primary care providers kind of remember that as the treatment and have therefore stayed away from Hep C. So there's a lot of training and education of providers that needs to happen as well. And then, the populations that carry this disease are often populations that are underserved, under-resourced. I mentioned people who inject drugs. There's a lot of Hep C as well in prisons, in the carceral settings. So that's another area that's important to kind of understand and work with in order to be able to get this treatment to people. We've been working for the last three years on proposing a program for elimination, and I'll just go through it very quickly. There's three components. The first one is about bringing the point of care diagnostic test to the US. When we were learning about programs internationally, it became clear that many of them had this test and was part of the success of their programs. So we did embark on a large collaboration with the FDA, NIH, and CDC to get this test approved in the US, and we were thrilled that the FDA approved it in June of this year. So that first part is already almost done. Now we have to get the machines and the tests kind of in the hands of providers and in the right places, but at least we have this FDA authorization now. The second part of the program is the subscription model. That's about getting access to cheaper drugs. And you may have heard of this. It's also referred to as the Netflix model. So where you pay a lump sum every month in Netflix, and then you get to watch as many movies or TV shows as you want. Well, it's kind of based on the same idea, where you provide a lump sum to the manufacturers, and in exchange you get unlimited access to the drugs. And that's a real incentive on the public health side to treat as many people as possible, since it's not costing you anything more to treat the extra additional people. This subscription model would not be for the entire population. It would really be focused on Medicaid patients, people who are uninsured, people who are in corrections, and people who are served by the Indian Health Service. On the Medicare side, what we're proposing is to eliminate cost sharing, but keep the regular price that's been negotiated between Medicare and the companies. And we do think that on the private sector side, we're not touching any of that, but because there would be increased testing and increased awareness around Hep C, we would see increased number of people being tested and treated for Hep C in that part of the population. The third component, though, is about empowering healthcare delivery. I mean, what we did learn from programs that have been run abroad, but also some more micro-elimination programs run in the United States, is that even access to diagnostics and drugs is not enough. You really do need the healthcare delivery system to be ready, willing, able, empowered, have resources to kind of do the work in the field, on the ground. And that involves expanding testing settings in the right places. It involves using new innovative methods like telehealth, like mobile units, vans, and also expanding the number of community workers who can help do this linkage to care once people have been diagnosed and provided with the treatment. So these are the three components of our plan. And I'll just give you a few updates about, so in order to finance that, we do need money from Congress. My boss, Francis Collins, has been working tirelessly the last 3 years to be able to work with various members of Congress to make this a reality. It was proposed by the Biden administration in March 2023, so about almost 2 years ago. We've worked with all the key agencies in the HHS system and the Bureau of Prisons to get their buy-in, to understand how this would be implemented. We have a 5-year implementation plan ready to go. Tim will talk to you more about the advocacy organizations, but they've been fantastic in terms of their willingness to support this and do outreach where possible. The two senators that are sponsoring this are Senator Cassidy from Louisiana and Senator Van Hollen from Maryland. So it's a nice bipartisan effort. Senator Cassidy, you might know, is a liver doctor. That's his specialty. So he's very familiar with Hep C and with the consequences of Hep C, with the cost of Hep C to states. And he was actually one of the key champions to start a pilot in Louisiana that was constructed along similar lines of what we're proposing with the subscription model. We've met with a lot of members of Congress, many of whom have shown interest in this. A key question, though, was how much is this going to cost the federal government? And we got an answer a couple of weeks ago from the Congressional Budget Office, who has estimated that this program will be cost saving to the federal government up to $6 billion, which so that's kind of a pretty high pay for. It's now that number's now in the public domain, so we can talk about it. In June, in my final slide, I'll just show you that in June, the CBO had issued an interim report where they'd done some calculations for Medicaid enrollees, and they'd shown that if you just double the number of Medicaid patients who are treated, the federal government would save $7 billion over 10 years. But we now have our final CBO score and showing the pay for that I mentioned. And that's so I think, you know, we see this program as sort of it's a no-brainer. It saves money, it saves lives, it's the right thing to do for people. And we really hope that it's going to get passed in the next Congress as early maybe as March of next year. So that's my formal presentation, and I think Tim's now going to talk to you a little bit more about the advocacy and the outreach efforts.
Thanks, Rachel, and Gary, thanks very much, and your team for having us here today. I'm Tim Leshin. I work for the Association of Schools and Programs of Public Health. We represent the accredited schools and programs across the country and really across the world that provide people with a master's in public health. And so a couple of years ago, Francis Collins called me when he was then working at the White House and said, "Can you come over and talk about Hep C?" And when Francis calls, you jump. And so I went running over there, of course, and we had a great conversation. And he told me all about what Rachel just explained to you. And to me, it is a no-brainer because he made it very clear, like, what other disease do we know about that we understand the science around? We've done the hard work to create a treatment. We now have this test. At that time we didn't, but you know, everything has sort of come together in order to actually cure a disease in our lifetime potentially. And I was very fortunate to work for Dr. Collins when he was head of the Human Genome Project. I did sort of the public policy work for him, and we worked on a bill called GINA, the Genetic Information Non-Discrimination Act, which prevents the misuse of genetic information in employment and insurance. And if you pay attention, you'll see every once in a while a form that you'll have to check off that you understand that there is that law in place that protects you from that. Now that bill took 13 years to get through. I worked on the final stages of that, and we were able to get it done. And President George W. Bush signed it, and that was a huge, huge victory. But it takes a long time to get legislation passed. So, you know, when I first learned about this, we were just trying to get it into the president's budget. It got into Biden's budget 2 years ago, and then again this year. And now, as Rachel said, Senators Cassidy and Van Hollen are working hard to try to have it pass in the Congress in order to provide the funds that we would need to implement this plan that Rachel explained. It's been a kind of a frustrating year as an advocate because it's been a lot of hurry up and wait because the bill had to be drafted. We had to wait for the Congressional Budget Office to score it. And now we were hoping there was a lot of conversation that the bill would be included in the final health package that Congress is looking at right now to pass before they leave for the holidays. And unfortunately, just because of politics, it wasn't included. But as Rachel mentioned, we're hearing it's in the press that the bill will be introduced early next year by Van Hollen and Cassidy, and there will then be a mad dash to try to have it be included either in the final budget package for fiscal year 2025, which hasn't passed yet, or in some other vehicle. But we are, hopeful now that it pays for itself, and it seems like, you know, most people understand the impact it would have that we can get this done, but nothing's easy in Congress, and so it's going to take a lot of advocacy to make that happen. We have a small coalition of many different kinds of groups, public health groups. The liver doctors are very much pushing this because they want to cure their patients of Hep C. We have a lot of hepatitis C organizations that are on board, and all sort of itching to do the typical knocking on doors on Capitol Hill and get this passed. And so I remain hopeful that we will. It would have been nice to have a nice Christmas present at the end of this year and wrapped it all up, but that's not usually how Congress works anyway. So I can't be too surprised, but now we just have to get ready to push to get this done in the new year. Happy to answer any questions.
So on that, if you have any questions, please put them in the Q&A, and we'll try to get them answered for you. While we're doing that, I'm going to turn to Rachel and ask, so how is this, I think it's a virus, how is it transmitted? Do we know how it's transmitted?
Yeah, sorry, I didn't say a lot about that. It's a bloodborne virus, so it's transmitted through contact with contaminated blood. In the US, the main mode of transmission is through contaminated needles through injection drug use. But if you used like a razor blade that had contamination, you could also like get contamination there. It's 10 times more transmissible than HIV, so it's like highly transmissible, and that's why we see so much transmission among people who inject drugs. In sort of countries outside of the US, or the mode of transition can just be kind of through like poor safety practices in hospitals. But in the US and in other kind of high income countries, it tends to be generally through the needle contamination.
Right.
Sorry, and just maybe the last thing is that when we before 1989, when we didn't know how to screen for it in blood, it happened. There was a lot of transfusion contamination and transmission as well. So that's why you see the baby boomer peak that I talked about in the first slide. A lot of that's through the blood, contaminated blood through transfusion, and then the millennial bump is more through the injection drug use.
I often wondered why the baby boomer numbers look the way they did, and you've now answered my question. Is that through blood transfusions we were not capturing that virus? So thank you for that. I walk away a little smarter about that. Because people are asymptomatic who have it, is there any way to risk score them, identify them? Or is it simply if you've been using injected drugs and things like that, that you want to get screened? What can you say to the public about getting folks screened?
The testing guidelines recommend like at least one test throughout in your lifetime, just for general public. But if you have risk factors, then you so it really depends on sort of the questions that the provider might ask the patient to kind of understand if they might be at higher risk for the transmission. But it's kind of, it's hard. If you're unaware about the disease, if you're asymptomatic, you might not think about asking for the test. And as I say, like primary care providers haven't typically sort of made it a priority to ask about hepatitis C screening.
We have a question about race and gender and health equity with Hep C. Is that a consideration?
Yes, absolutely. I mean, I think we see a very high numbers in American Indian, Native American populations, and yes, I mean it's definitely a consideration.
And speak a little bit more about Native American. I'm assuming not injected drug use, or is there something else going on with them?
Yeah, I don't know. I see in the chat people maybe discussing about injection, that it doesn't have to be through injection, but I think the numbers I've seen are definitely, I mean, it's definitely more common in, just because of the mode of transmission is more common with people who inject drugs. I think the numbers I've seen is actually pretty low for sexual transmission in birth. I mean, I think it's not impossible, but it's not, it's pretty low. So I think the important thing is and then the carceral settings as well. So it could be, so for example, unsafe tattoo practices that can also lead to the contamination. So anything where there's kind of unsafe use or sharing of needles or razors or blades, that's kind of what you need to be, then you're likely to see kind of higher levels of hepatitis C in these populations.
And I see in the chat, is it also possible to transmit by birth? I mean, is that a possibility?
So I'm not an expert, but I think it's pretty rare. I think it does happen, but it's not like one of the main. It's not a. I don't think it's like a key mode of transmission. Although, I mean, I did mention the pregnant. So you know, whether should you be treating people who are pregnant, because there's no clinical trials. There's a registry for people who are pregnant, but there's no clinical trials. And of course, you want to be as safe as possible for the mother and the baby with drugs. So I think that's a key area where we need kind of more evidence in terms of whether or not it's safe to treat people. I've heard anecdotally that some providers do treat in the third trimester of pregnancy. So I guess there must be some concern about the transmission during that final trimester and birth.
And so I'm assuming it's safe for pregnant women to go through the course.
Well, I think it's not. So the FDA doesn't, it's not like approved by the FDA. So I think providers make informed decisions, like depending on how high they think the risk is for the mother and the baby. But I have heard anecdotally that some providers are willing to do that, but others may not be, who are maybe less familiar with, who maybe treat less patients who are less familiar with how things might play out.
Yeah. And we always look at geography, and so does geography play a role here in terms of risk?
Yeah, so I think what you'll tend to see is it mirrors the opioid epidemic. So a lot of the states who have high who've had a lot of the problems with the opioid crisis also have high hepatitis C. I didn't relook at the stats for our call, but I believe it, Maine, West Virginia have there are two examples where there's Tennessee, where there's very high rates, but they do, and as I said, it mirrors the opioid crisis. So that's kind of an easy way to look at where you're going to have high rates. It's going to be in these areas.
Yeah. And there was a question about prior authorization and insurance, and how or can we address those in any way, and particularly in the plan that you're thinking about? Just for private insurance. I mean, I think I would assume so.
Yeah, because I think the concern with private insurance is that because the costs won't change for either for the patient or for the insurer. So why would there be an incentive to increase test and treat? I think what we're hoping is that the increased publicity and awareness in the public, in the provider population, will lead people to ask or be offered for tests more often, especially with the point of care tests, where you can actually get test result the same day, and you're not having to come back two or three times to get your treatment or get your prescription. So that won't remove prior authorization barriers, but it will certainly kind of put pressure on the insurers to kind of they'll have more requests for filling the prescriptions.
I'm sorry, please go.
If I could just add to that, I mean,
go ahead, Tim.
Go ahead. No, go ahead, Rachel, you finish.
No, I think our plan doesn't, or our initiative doesn't specifically have items that address private insurance, but we're hoping that by kind of osmosis, and given everything else that would be happening in the Medicaid space, in the Medicare space, that that by default there would be an increase of testing and treatment in the private insurance space.
Tim, you
Yeah,
want to say something?
you sort of made my point, but just to reemphasize, the plan we're talking about is trying to get to the people who don't have private insurance, people who, don't have good access to healthcare, but they should have access to a quick diagnostic test and access to the medication, which will cure them in 8 to 10 weeks, right? So we do think that that will also affect the private market as well, but that's the population we're trying to get to with this plan.
And the assumption being that those who have private health insurance will get screened, or there won't be just help me understand, what are you thinking about in terms of the private insurance folks?
Well, I mean, in my view, people could do that now. I think Rachel's right. It's really, that's going to be all around the publicity around what is Hep C. There is a cure, and if you have insurance, you can, go through your provider and ask them to screen you and then give you the treatment. But it's the people that can't afford or aren't able to get that treatment now that are at most risk of having Hep C. So we're trying to get to the biggest population of people with Hep C in order to make an impact there.
So my experience with private insurance, and happy to be wrong here, that if a clinician starts to mass screen his population, or decide to do the baby boomers and the Gen Z population, for example, that could get you kicked out of a network pretty quickly, particularly if you're starting to find cases of that. So it's not just the prior authorization; it's the fact that you sort of identified patients who are going to need an expensive medication that it could also create problems.
Yeah, I'm not quite sure how you're going to solve that problem in our healthcare system,
Yeah.
but that's what I mean. Like, that's a truism across any disease and any medication that's out there.
Yeah.
But we can, I believe, solve this problem for the majority of the people who are at risk of having Hep C. And if we can get to that population, I think the private insurance piece is, I'm no fan of private insurance, but I do think like that part will sort itself out as well as it can in our current system.
So if a person is quote unquote cured, they've gotten the treatment, are they now cannot pass the virus along, so that presumably if they don't get the treatment, they can spread the virus, and if they do get the treatment, they will not spread the virus. Is that a logical assumption?
That's correct, Gary. The treatment is 95 to 98% effective, which is really a miracle of modern science. However, you can recontract the disease. So if you're exposed again to the virus, then you can get it. You can get it again. So ideally, we'd want a vaccine. That would be that's the ideal world where you're immunized against it. But I've learned a lot about the vaccine development in this space, and it's the virus itself is it's a very difficult virus to develop a vaccine for. So there's been progress, but it's actually the progress stalled a little bit once the drugs came on the market, because it was felt like, well, why the vaccine was less of a priority because there was a cure. But nonetheless, to really eradicate the disease, we would need a vaccine, and that's not available yet.
Tim, is the federal government doing anything to negotiate with the pharmaceutical about the cost of medication?
Well, that's the whole plan here. If we can get Congress to pass this and there's funds available, then they have funds to do that negotiation. That's a tricky issue on the Hill, right? In general, Republicans have been opposed to anything that restricts the cost of medications. But the current administration doesn't really have that ability on this drug to do those negotiations yet. But if we have the funds and this subscription model that Rachel mentioned is put in place, then that's exactly what they would do. And there are those two companies she mentioned that are, the targets for those negotiations. And I think my hope is that when they see the dollars that are there, they're going to say, well, that's revenue, even if it's not as much revenue as we would like, that they'll be willing to negotiate.
One of the things that I would imagine, if there are 4 million people who were infected in the country, and you're being successful, and we want you to be successful doing this, it certainly sort of at some point puts those companies, at least for that particular disease, out of business, right? Because you've effectively, every time you cure someone, unless they get reinfected, you actually, I would assume that a lot of times they would like to have a continuous population that they're treating, but in this particular instance, you're actually curing them. Is that correct?
Yeah, but I mean, I get what you're saying. That is usually the typical business model. You want the Ozempic where people have to take it for the rest of their life, right? But they developed this drug in order to cure the disease. So, unfortunately, just knowing how this disease has gone, right, it's going to take a long time to cure everybody of Hep C. So I think they'll have plenty of business for years to come.
Yeah, maybe I'll add to what Tim said, two other things. So there are patent expiries. So at some point, even though like the companies, they put in new patents to kind of slightly change things, but there is patent expiry. So there is some incentive for the companies to play before the patents expire.
Sure.
So that's one thing. And then the second thing is, these 4 million people that are not cured yet, they're hard to reach populations. So the companies have not been able to reach that group. So essentially, why we think the subscription model is attractive to the companies is that they're actually not be able to sell or make revenue out of the drugs for that population. And what we're saying to them is, we'll give you a lump sum that corresponds, broadly to what you're getting right now for that population. So you won't lose money, but in exchange, we'll, give us unlimited access to the drugs. And then then on the public healthcare delivery side, we're really motivated to find every one of these 4 million people as to the best of our abilities. So that's why we think it's kind of we've set it up so that the incentives for pharma are kind of there for them to be willing to play with the subscription model.
I recently saw that CMS came up with something like this for sickle cell. But I think it was a more kind of pay for performance, in the sense that it was a value based. So if you gave the medication and it worked, you then got paid essentially. Is that a workable model here, or something close to that?
Well, I think in our case it's a little different because like the sickle cell treatment is incredibly, like you have to get the person in a hospital. It's very like high burden for people to get the sickle cell treatment, whereas for like Hep C is really like, you just take your packet of pills home, take them for 8 to 12 weeks, and then so it's much less burdensome to treat people with Hep C. So I think and also we have the data, we know it's 95 to 98% effective. So there's not a lot of concern. Like if you're able to take most of your course of treatment, you're going to get cured. So I think we didn't go down the road of like the kind of the the sickle cell, like you get paid if the person gets cured. I mean, it's interesting to think about, but I think we looked at anyway.
You said something there that I quite frankly made an assumption and didn't ask. So it's not an infusion. These are not infusion medications. These are pills.
It's just a pill. Like it's very, very small molecule. Just take it like an Advil almost. And almost no side effects. It's very, like, it really is miraculous kind of on many levels in terms of its ease of taking it and adherence. But of course, once you get to populations who are incarcerated or maybe who are unhoused, it's not, it does become complicated. So we have to have a lot of like healthcare delivery support for the folks who'll need it to be able to take their 8 to 12 week course of treatment.
Sure. And if you're successful, do you get close to something like herd immunity here? If you take that 4 million and 60% of them, or some number like that, does that get you?
I think so. I mean, we think so. We hope so. I mean, of course, without the vaccine, it's never gonna be 100%.
Sure.
But we could certainly make a huge dent in terms of like reducing the level of the disease in the population. I mean, the country of Egypt basically is not 100% eliminated, but largely eliminated the disease. So it is possible to get to very, very low numbers.
And Tim, because incarcerated populations have a high burden for this, how have the jails and prisons responded, or they have not responded?
No, I mean, Rachel probably knows more than I do about this, but my sense is they are excited to do this because, they don't want to have people transmitting Hep C in their jails and prisons. And if they can, offer this cure, it's, right now it's just too expensive for them to do. But if they have this negotiated price, and this funding from Congress, they could offer it and really make a big dent in their population. Rachel, do you have more?
Yeah, just say we had to kind of like going into this had to understand a lot more about the carceral system. So there's the Bureau of Prisons, there's the state prisons, and then there's the jails, which are more county under the jurisdiction of sheriffs or kind of local authorities. So it is very complicated. The Federal Bureau of Prisons will be kind of the easiest place for us because they'll just get some money from the bill, and then they'll test and treat their population accordingly. So that one's going to be, let's call it, fairly easy. But we think at the state level it will be also like it will be definitely doable at the state prison level, but you're working with the states, you're not working with a federal entity. The hardest place is going to be the jails because the turnaround is so quick. So it's not a priority for jails to be testing people at intake, like for even any disease. So so I think that's going to be more case by case. And my sense is we would start, like, I think my ideal way of doing it, we'd start with kind of the early adopters, people who are champions of wanting to kind of do this in their county, in their regions, and then there'd be best practices for places that want to kind of come on a little bit later. But it is definitely doable.
There's a question in the chat about FQHCs, Rachel. I assume that's one of the places that would get this funding and do this testing and all of that, right?
Yeah, super important, the FQHCs. We've been working closely with HRSA to kind of figure out that there's money in the bill for HRSA for the FQHCs to increase testing, linkage to care, access to the treatment. We're hoping the FQHCs would have the machine for the test. It is, I guess we didn't talk too much about the physical part of the test, but it's easy to do. It's a finger stick, so you just kind of draw a little bit of blood from the finger. So you don't need a phlebotomist, you don't need like you don't need people who are trained to be able to draw the blood, but you do need like what is kind of a box machine to be able to run the cartridge, and not every place like either has the box machine or has the space to run the thing or is able to maintain the card. So there's a little bit of logistics and thinking that will go around, like making sure the places that need them have the test, but the FQHCs are very high on the list, and there's money in the bill for that.
And the presumably the cost of the test itself is not large. I mean, this is not like a MCID test of $600. I'm sure this is like what, $10 or $15 or something like that.
I think that's a good question. I actually don't know for sure, so it'd have to be confirmed. I think it's closer to $30 or $40 a test. So it's not great for like general population. So like you wouldn't want to screen the whole population with a test that's that expensive. What we're hoping though is so again, not available yet in the US, but there's some very quick antibody tests that you can do in less than a minute and they're very cheap. And if you come up positive on the antibody, then you can get in the same visit, because it's only 1 minute to do the antibody, then you can get the reflex test with the RNA that's more involved. So then you're not using up, scarce tests and expensive tests on everyone at the first go. But we're not quite there yet. We have to that will involve some kind of working with the companies who are willing to kind of put their tests through the FDA authorization process. But it is, I think the cost of the test is still something that we'll have to. It will be a challenge because it's not like super cheap. But our first step this year was like, well, let's just get it approved. At least it's available. And then we'll figure out how to make it more cost effective for the testing part.
And the machine itself, and maybe you don't know, is a standalone, because some of these, I remember with the COVID test, there were other tests that you could run with it. Is that something similar here, or is it just solely for this particular?
Yeah, no, that's a great question. It's so the company is Cepheid, that's the manufacturer, and so the box machine can run different types of tests, but the cartridge itself is Hep C specific. So you could run a flu test, but you'd need a different cartridge. Yeah.
Well, that's enough opportunity for the FQHCs if they. I don't know if you need a clear license to do that or what, but it could be an opportunity for that.
Yeah, exactly. And you need a CLIA waiver for this test. It's a CLIA waived test, but you still need your waiver through CMS.
Exactly.
Yeah.
So Tim, what can patient advocates do here? It's it's interesting that you have a cure that's sitting on the shelf, and it's a little confounding to think about that. Well, before you answer that question, I want to go a little bit further upstream, because one of the things that fascinated me about how providers were putting in prior authorization is that they wanted you to have cirrhosis of the liver first before they would give you the test. I mean, isn't the horse out of the stable by that point? I mean, I'm a little confused about allowing bodily damage.
I think that was just all about cost, right? It wasn't about what was right, best for the patient. It was about restricting the amount of people getting access to the drug because it costs so much. So right, it's ridiculous on its face in my mind that they would wait that long. We need to catch people when they're newly infected so they can get treated and they don't have any of those kinds of consequences. In terms of what patient advocates can do, they are really urged. I'm here to urge every patient that cares about this or is infected by Hep C or knows family and friends who are, to start talking to their members of Congress and demanding that this piece of legislation passes the Congress. It's very clear that this not only does this cure the disease, but it won't cost. It'll save the government money. It won't cost the government money, and so there's really no excuse for not getting it done. But any piece of legislation that gets passed in Congress happens primarily because the American public are telling their members of Congress, we need to do this. And if you're not at the table, you're on the menu, right? So they gotta hear from people who care about this. And we will be doing, once the bill is formally introduced, the coalition will be urging all of our organizations to get their patients and doctors and public health experts to make that case to Congress. And I really am hopeful that we can do this.
And so I mean, it sounds like everything's set up here for a real public health program. And I guess as you were talking, the thing that struck me is when we get to the place where we have a cure for a disease, we ought to think about it a little bit differently in terms of funding, and it would be a good place for Congress to really set up a program that says, well, if you can cure 95% of the population, particularly with an infectious disease, right? So that we don't have to constantly do this. You know, there should be some mechanisms in place to say, okay, if the clinical evidence is there that we can cure, and cure is a big word, a disease.
It is.
Why wouldn't we? Help me understand why members of Congress are it can't be just money. You just can't tell me that it's money that just is the obstacle here.
Well, I mean, it's always about money, right? But I think, you know, if we're, you know, really being realistic, you know, a lot of members of Congress are not focused on treating the population we're talking about. They are focused on, you know, other kinds of diseases that they think affect different kinds of populations. And so there is a bit of a piece to this where we need to make sure that members of Congress understand that their constituents are impacted by this quite a bit. It doesn't really matter, you know, who has the disease. This is something we can actually cure. And you're right, that's a big word. When I worked at the NIH, we were always hoping that there were going to be some of these breakthroughs that we could talk about that cured disease. And, you know, the federal government spends almost $50 billion trying to better understand a whole host of diseases in order to try to cure them. This was one where we've actually had this great success. So I really do think if, you know, and it's true when Francis Collins talks to members of Congress, they get it. It's kind of a no-brainer once he explains it to them. So I think there's just a big PR campaign that needs to happen and GR government relations campaign that needs to happen in order to get it done.
I think there was a question about whether, given the nature of the lab test now, should it become part of some routine test? Because my understanding would be you'd only need to test it once in a lifetime. Is that correct?
Yes, it's once in a lifetime if you don't have risk factors, but if you have risk factors, then you can get it as often as the provider and the patient think is necessary. So technically, like that piece is in place. It's just a lack of awareness. Like people don't know to ask about it, and providers don't know to offer it. And so, but technically, it is there. There's at least one test, and maybe several if you're at high risk, that are covered on the test side.
And Tim, did I hear you that because of the nature of the risk population, there may be some reluctance there, a kind of bias that has gotten built into the thinking?
Yeah, I mean, we've seen this in public health, you know, since the field started, right? That there is a disproportionate impact on certain populations, and there are some folks who feel like we shouldn't be spending our time and resources on reaching that population. Luckily, a lot of people disagree with that, and Congress has funded the CDC and the NIH and really tried to get after these vulnerable populations in order to try to help them with all sorts of different diseases. But yes, we believe there is some bias, but I think that can be overcome with some education.
Well, it just seems that, as you suggest, the moment for the general public to raise its voice is incredibly important here in order to move this along. And if I'm hearing you correctly, sometime in the next Congress that this will get submitted as a piece of legislation.
Yes, well, there was a press report this week that it was going to get introduced in the early part of next year. So we fully expect that, and we'll be working with Senators Cassidy and Van Hollen, you know, to make sure that not only is it introduced, but that it goes to regular order and gets through the process and gets going. Because if they can pass it, then the big challenge will be to have Department of Health and Human Services implement the program. That's even as hard as it is to get legislation passed, it's harder to start a new program and get it going in a timely fashion and have it be effective.
And I'm going to suggest that in the minority communities, this is probably not well understood. That first of all, that hepatitis C is a risk. Particularly, I know when we were doing work in HIV, the infection from people being released from prisons and things like that contribute to the rate. And I would assume that with hepatitis C, we're likely to see something like that as well.
I mean, I don't have the stats, but that makes sense, right? Because it's such a high population of folks who have Hep C who are in prisons and jails, right?
Yeah, and so there's a real need as you're moving towards legislation to reach out to some of these communities that probably it's not on their radar.
But that's part of the bill too, to educate populations in order to get them to realize that this is an important issue and that they should be asking for the testing and getting the treatment.
So how can you keep people informed as the bill starts to get introduced or is introduced? How can folks reach you or the organizations that you've put together or join the coalition? What can be done here?
Well, of course, we'll keep you informed, Gary, so you can make sure your constituency is on top of this, and we hope to have them involved in the advocacy. But people can reach me. I'm easily emailed at TimLeshan@aspPH.org. I'm easy to find on the internet. There's our association has all my contact information up on the web. So I'm happy to hear from folks who want to get involved, and if there are organizations on this call that want to be part of the coalition, there's no cost. It's very easy to join the coalition, and we can keep you informed because we do that with the whole coalition.
And is the private sector engaged? You know, we talked about the plans, but obviously the manufacturers, the those who have created the test and all of that, are they fully engaged here as well? Do you know?
I wouldn't say they're fully engaged. They're certainly not part of our coalition at this point.
Right.
But they're engaged for their own interest. I'll say it that way.
Yeah. Fair enough. Fair enough. Look, you know, we're getting smarter and smarter with the science, and the fact that we have this breakthrough, and quite honestly, I thought it was an infusion, which raises a whole lot of other things. But if it's just a pill,
Right.
And you're denying access and you're not investing, there's a willfulness there that is really unfortunate. And I'm not really sure I understand why members of Congress have such trouble, or their staff grasping the moment.
Well, I think, just a lot of people don't know about it yet. I think there's only it's been very few meetings that I've had where they've said, oh, this is a bad idea. They've worried about the cost and, some other technical issues, but I don't think there's going to be a huge opposition for it.
Right.
It's just a question of educating. So, yeah, it's the great thing is it's such a no-brainer that, and the money piece too, saving money, that's what the new Congress is going to be all about. Well, here's $6.5 billion for you.
Well, Tim, I love your optimism. I hope it's infectious. And certainly NMQF will try to support you any way we can, because I think this is really an important chapter that needs to be closed in terms of being able to get people the healthcare that they need. So I want to thank you and Rachel for really an informative discussion. And hopefully it will lead to others joining. I think there was one more question. Let me make sure. I hate to leave a question unanswered. Oh, someone's asking about the cost of treatment. Oh, someone's asking about to update the guidelines to make routine testing and treatment for at-risk populations a standard of practice. Are there guidelines right now around this, clinical guidelines?
Yeah. So the CDC has guidelines. CMS has a national coverage decision, but it's actually very outdated. It was issued in 2013, and we've been really doing everything we can to try and get CMS to update this national coverage decision, but unfortunately it hasn't happened yet. So we're trying to we're working on that.
All right. Well, we'll want to take a look at that coverage. And we'll reach out to you and want to pay attention to that coverage decision.
Yeah.
Well, again, thank you so much. Appreciate the
Thank you,
conversation. And if we can be helpful, please let us know.
Yeah. Thank you so much for the invitation. We
you.
appreciate it. Thank you.
Great.
Yeah.
Bye-bye.
Take care.